disorders. We have with us Dr. Vasantha Kamath, who will be briefing about multi-system inflammatory syndrome.
Welcome, Dr. Vasantha Kamath, Madam.
This is pointer. No, I don't want this. This is changing slide is this one. You point anything. It's only small. Yes.
Respected chairpersons and learned audience. My talk is on multi-system inflammatory syndrome in adults, and I will stick to my timings. COVID-19 is increasingly recognized to have protean range of clinical manifestations with a broad spectrum of disease severity in adults, ranging from respiratory illness to hyperinflammatory and coagulopathic complications. When the epidemic began in China in late December 2019, case reports of pediatric illness were relatively rare, and almost all children had mild clinical course. However, growing number of reports from UK, Italy, and US described a severe inflammatory syndrome in children similar to Kawasaki disease, which was known as pediatric inflammatory multisystem syndrome, temporarily associated with COVID, PIMSTS, and later US Center for CDC renamed this as MISC. Multisystem inflammatory syndrome is rare, but a severe complication of COVID-2 that can occur around 2 to 12 weeks after the initial infection and manifests as a febrile syndrome leading to inflammation of the heart, lungs, brain, kidney, skin, eyes, and gastrointestinal tract. Initially described in children as MISC in April 2020, but later reported in adults, MISA, around June 2020. Children with asthma, cardiovascular complication, and immune suppression are at risk, so also adults with comorbidities. Although a serious complication requiring ICU admission, children have a good prognosis with proper medical care. CDC has a working case definition of MISA, which includes age 21 years or older, presence of a severe illness requiring hospitalization for 24 hours or more of illness, and the patient should not have a more likely alternative diagnosis to explain the illness, like bacterial sepsis or exacerbation of a chronic medical condition. There are diagnostic criteria, clinical and laboratory. The clinical criteria is subjective fever or documented fever of 38 degrees centigrade or more for 24 hours or more prior to hospitalization or within the first 3 days of hospitalization, plus at least 3 of the following clinical criteria occurring prior to hospitalization or within the first 3 days of hospitalization, of which one must be primary clinical criteria. The primary clinical criteria are severe cardiac illness, which includes myocarditis, pericarditis, coronary artery dilatation or aneurysm, new onset right or left ventricular dysfunction, of which left ventricular ejection fraction is less than 50%, second or third degree AV block or ventricular tachycardia, rash, and non-purulent conjunctivitis. The secondary clinical criteria is new onset neurological signs and symptoms, which includes encephalopathy in a patient without prior cognitive impairment, seizures, meningeal signs, or peripheral neuropathy, including GB syndrome. Shock or hypotension not attributable to medical therapy like sedation or renal replacement therapy, abdominal pain, vomiting, or diarrhea, and a platelet count of less than 1.5 lakhs. The lab criteria: presence of laboratory evidence of inflammation and COVID infection, elevated levels of at least 2 of the following: CRP, ferritin, IL-6, ESR, and procalcitonin, and a positive COVID-2 test during the current illness by RT-PCR antigen detection or serology for antibodies. Coming to the pathophysiology, there are 3 stages. First is the early infection phase, where the clinical features are entirely because of the actively replicating virus. Second is a pulmonary phase, where the clinical features are because of viral replication and host inflammatory response. Third is hyperinflammation phase, where the clinical features are entirely because of the host inflammatory response. The antibodies can augment the inflammatory response by triggering the host immune response with antibody-dependent enhancement of viral entry and amplification of viral replication, as seen in dengue. There is abnormal immune response to the virus or antibody-mediated process with some clinical similarities to Kawasaki, toxic shock syndrome, and cytokine release syndrome. Given the high proportion of cases with the positive antibodies, it is antibody-mediated dysregulated immune complex activation causing direct endothelial damage and thromboinflammation. The virus-infected cells release interferons, causing the nearby cells to heighten the antiviral response. So early interferons, rapid viral clearance, less inflammation, mild disease. Delayed interferons, slow viral clearance, more inflammation, and severe disease, including MIS. The clinical features are fever, mucocutaneous rash, erythematous rash or maculopapular rash, non-purulent conjunctivitis, gastrointestinal, abdominal pain, vomiting, and diarrhea, neurological, headache, altered vision, confusion, and meningitis signs, cardiovascular, decreased left ventricular ejection fraction, myocarditis, and pericarditis. The Tier 1 tests are CBC, TCDC, complete metabolic panel, ESR of more than 40 millimeters in the first hour, CRP of more than 5 milligram per liter, absolute lymphocyte count of less than 1,000 cells per cubic millimeter, platelet count of less than 1.5 lakhs, neutrophilia, decreased albumin, and a sodium less than 135 milliequivalents per liter. Tests for COVID, RT-PCR, serology for antibodies, antigen detection. Microbiological evaluation to rule out other causes like dengue, scrub typhus, malaria, leptospira, and enteric fever. Tier 2 tests, evaluation for cytokine release, IL-6 and procalcitonin, evaluation for coagulopathy, PT and APTT, and evaluation for myocarditis, echocardiogram, anti-proBNP, and troponins. Now, the MIS is divided into 4 clinical types. This is entirely for treatment purpose. MIS without shock. MIS with shock, anyone who has MIS and has features of shock in the form of tachycardia and hypotension requiring inotropic support. MIS with a multi-organ dysfunction, anyone who has MIS and has 2 or more organ involvement, respiratory, cardiac, CNS, liver, or renal. Refractory MIS, anyone who has MIS and has not responded to first tier therapy like IVIG and glucocorticoids for more than 48 hours. In children, there is one more, MISC with Kawasaki phenotype. Children who meet complete or incomplete Kawasaki disease criteria as defined by the American Heart Association. Now, even though the system involved mainly in MIS is cardiovascular and gastrointestinal, there can be involvement of hematological, renal, respiratory, mucocutaneous, musculoskeletal, and neurological involvement. There is diversity in phenotype among different groups and different age groups. Younger children presenting the mucocutaneous manifestation, while young adults present with the gastrointestinal and myocarditis. So coming to the studies, the first reported case of CDC morbidity mortality weekly reports included 11 MISA patients based on data collected from March to August 2020, 7 of whom presented with a cardiogenic shock. In October 2020, CDC published initial review of 27 cases with a clinical course consistent with the MISA, and they had heterogeneous involvement of cardiac, gastrointestinal, dermatological, and neurological symptoms without severe respiratory system involvement at presentation. Feldstein et al. In his study illustrated that as compared with severe COVID, patients with MIS are more likely to demonstrate cardiorespiratory involvement and cardiovascular without respiratory involvement on presentation. Bastag et al. In a recent review of 51 cases with MISA highlighted that cardiovascular involvement has been the most frequently reported finding, followed by gastrointestinal manifestations. Bastag et al. And Hickman et al. Demonstrated that though serology consistent with the prior COVID is necessary to fulfill the case definition of MISA, it has a poor prognostic and diagnostic role. And Henderson et al. Demonstrated the role of immunoregulatory therapies in MISA. Now, COVID and MISA are almost always similar, the symptoms, hence difficult to differentiate between the two. Those diagnosed with severe or critical acute COVID, a proportion are cases of MISA. 60% of MISA had overlapping acute COVID symptoms. Severe COVID, hyperinflammation, and extrapulmonary organ dysfunction described in hospitalized people are almost always accompanied with a severe respiratory failure. Whereas in MIS, there are minimal respiratory symptoms, less of hypoxemia or X-ray abnormalities, but more of extrapulmonary involvement. Several case reports of MISA following COVID vaccination has been reported. The timeline could be similar like MIS happening post-infection, 4 to 6 weeks post-vaccination in children and 12 weeks in adults. Clinical features and management are the same. The vaccine adverse event reporting system co-managed by CDC and US FDA used for monitoring adverse reaction following COVID have added MIS-C and MIS-A as an adverse event post-vaccination. Now, people with history of MIS-C or MIS-A may choose to be vaccinated. This reduces the risk of severe disease, including potential recurrence of MIS after reinfection. And consideration for vaccination is complete clinical recovery from MIS-C or MIS-A, including return to normal cardiac function. At least 90 days after the diagnosis of MIS-C or MIS-A, people who are elderly with underlying medical conditions should definitely be vaccinated because the chances of COVID being very severe and critical is more in them. And immunomodulatory therapy is not a contraindication for giving a vaccination, only the timing should be different. There should be at least 2 weeks gap. And the advantages of COVID vaccine is much more than the side effects of the vaccine. Now coming to the difference between C and A. C less than 21 years, A is 21 and above. C is more common, A is less common. Pathophysiology is same in both, dysregulated immune complex activation. C is less severe, A is more severe. In C, the initial COVID infection is asymptomatic or mild. Here it is very severe and critical. More of mucocutaneous manifestation in C. In A, it is cardiovascular and gastrointestinal manifestation. Treatment is supportive for both. Prognosis is good in C with a mortality of 1%. In MISA, the mortality is 7%. And MIS is definitely recognized as separate phenomenon due to frequent lack of severe respiratory involvement. Coming to the treatment, IVIG influences the number and function of regulatory T cells, which help control inflammation. Based on its mechanism of action, IVIG is considered first-tier therapy, and steroids can be used as adjunctive therapy in case of distributive shock. The proposed starting dose of IVIG is 2 grams per kg per day, not more than 100 grams per day should be given. And this should be given as a continuous infusion over 8 to 12 hours. Anakinra, a recombinant IL-1 receptor antagonist, is a well-known drug due to its role in the management of various autoimmune conditions. It has been shown to have a quick onset of action, a short half-life of 4 hours, and a large therapeutic window. Moreover, anakinra is rather preferred over tocilizumab, given its safety profile and lesser myelosuppressive and hepatotoxic effects. In its recommendation regarding MISA, the American College of Rheumatology has mentioned that anakinra can be considered as an additional therapy in patients refractory to IVIG and glucocorticoids. The proposed starting dose is 4 mg per kg per day subcutaneously, with an eventual plan to taper the dose based on clinical recovery and resolution of markers of inflammation. So this algorithm, MIS without shock, IVIG, 2 grams per kg per day, with the IV methylprednisolone, 500 mg per day, both can be started simultaneously, and they decrease the tissue inflammation and myocardial injury. In case there is shock, in addition to IVIG and IV methylprednisolone, inotropic support, epinephrine for cardiogenic shock and norepinephrine for vasodilatory shock. In case there is MODS, proper perfusion of organs has to be ensured. If symptoms persist for more than 48 hours or there is disease progression despite above treatment, consider refractory disease, escalate the dose of methylprednisolone to 1 gram per day and add anakinra 4 milligram per kg per day subcutaneously. Supportive care is a mainstay in the management. Significant number may require vasopressor support, thromboprophylaxis with a low dose aspirin for all 75 milligram per day, provided the platelet count is more than 80,000 cells per cubic millimeter. Therapeutic anticoagulation in those where there is documented thrombosis, coronary artery aneurysm, significant left ventricular dysfunction, enoxaparin 1 milligram per kg continued till there is normal left ventricular ejection fraction or normal coronary arteries are confirmed. Cardiac follow-up with a serial echo for latent development of coronary artery aneurysm and monitoring of cardiac function. COVID vaccination to prevent MIS by lowering the risk of preceding COVID infection. So to conclude, consider MISA in adults presenting with high fever and broad constellation of severe extrapulmonary multi-organ dysfunction without severe respiratory illness. They manifest most often with a cardiovascular and gastrointestinal involvement. There is history of COVID infection or exposure to a person with a COVID 2 to 5 weeks earlier. Consider testing for COVID even in those who denied COVID infection or contact. Test for RT-PCR, rapid antigen test, serology for antibodies, including measuring the titer. Underlying etiopathogenesis is antibody-mediated dysregulated immune complex activation, causing direct endothelial damage and thromboinflammation. IVIG and corticosteroid is effective and has to be commenced as soon as possible after ruling out focal source for sepsis. Escalate promptly to intensive care for further support. Although extrapulmonary manifestation with elevated lab markers of coagulopathy and inflammation is also seen in severe COVID, MIS is distinct because it presents as post-acute, post-infectious illness, often after a period of recovery, and is heralded by onset of new symptoms. Thank you all for a very patient hearing.
Thank you, ma'am, for that compact and concise presentation. I think this will be very useful for all the physicians here.
Questions? 2 questions are allowed for this session. Please, audience.
If there are no questions, yes.
And when we come across so many cases, we are alerted. Is it mandatory now and it is going on?
Of course, it's going on in different countries also. Even in India, so many COVID infections are reported even today. And most of them have long COVID syndrome who has suffered from COVID. Up to 1 year because of the cardiac manifestations.
Ma'am, that was an excellent talk. I just wanted to ask you, since MISA is just a dysregulated immune response, it could occur in infections other than COVID as well, isn't it? So has this been reported in non-COVID illnesses? Because it's something like a cytokine storm and something similar to that, which can happen with multitude of infections. So just your thoughts on that.
See, I referred, this question I anticipated. And of course, I referred many references. Till now, this MISA is not reported in other infection apart from COVID. This is emphatic.
So it's just not been reported, but
No.
probably people have to start looking at it
Yeah,
from
they
that
may,
perspective
they may have to,
going
but
forward.
they've also looked into it and they say they are not reported.
Right. Thank you so
Right.
much.
Thank you, ma'am, for delivering such a compelling talk. Your insights and enthusiasm are truly appreciated. I cordially invite our chairpersons to present a memento to Dr. Vasanta Kamath as an expression of our gratitude.